use your mouse to point to this because in the recording, the mouse comes out,
Okay,
but not
great.
this.
Okay, that's great. Thanks a lot.
You can start.
Okay, guys. Good morning. Let's get started. My name's Rosemary Sampogna. I study kidney development, and this is a little bit weird having development in the middle of your lectures because development happens first. But one of the interesting things that I'm going to tell you in my talk is that a lot of the diseases we see later in life, chronic kidney disease, hypertension, cardiovascular disease, end-stage renal disease, have their origins in what goes on during intrauterine life. I don't have any disclosures. So the three objectives that I think are important are to understand intrauterine. There are three main stages of kidney development. We're going to talk about those stages. We're also going to talk about the mechanisms of development of the lower urinary system, mainly ureter and bladder, and talk about some of the abnormalities, both genetic and acquired, of urinary system development. Congenital kidney and urinary tract abnormalities comprise an important number of congenital defects. 1 out of 500 newborns have gross kidney abnormalities, and this plays a significant role in kidney diseases later in life. And our goal in the lab is to understand what's going on from the genetic and molecular standpoint that specify the 3D structure and the function of the kidney. Once we have a framework, we use this to try to understand human diseases that happen because of genetic errors or because of intrauterine environment that causes growth retardation and defects in kidney development. I'll talk later about a case that has a genetic basis and how the same disease might present differently in different people in a family, but let's do that later. And when kidney development starts, already there are 3 embryonic germ layers. There's the endoderm, mesoderm, and ectoderm. And what the kidney derives from each of these, from the endoderm, the bladder epithelium. The mesoderm really makes up most of the urogenital system. It makes up the kidney, ureters, and bladder. And the ectoderm provides the innervation. This is a schematic of what's going on in the embryo. This is now about week 2 to 3 of gastrulation, and the embryo's a trilaminar structure. So this is in human days, day 17. There are these 3 primitive layers. In blue is the ectoderm. In this pinkish red is the mesoderm, and that's where the urogenital system will derive from. And here in yellow is the endoderm. And this is going to form the gut, liver, and lungs. And the ectoderm is going to form the nervous system and the epidermis. So there's this thin sheet here. It's called a mesodermal sheet. And here you can see it's expanding, and it's forming over here this paraxial means next to the spinal cord, mesoderm. And these are future somites. And these are segmented masses or protrusions of mesoderm that they develop in a cranial to caudal axis. And that they will mainly form the vertebrae, bones, skeletal muscle, and connective tissue. A couple of days later, this intermediate mesoderm is here. It's this small, more rust-colored mass of cells next to these future somites. And it's from here that's going to, the renal system is going to arise. So right here by day 21, we see an intermediate mesoderm. Okay. And here, if you look again, this is a cross-section, and here's the intermediate mesoderm. It's going to form the kidney and the gonads. So there are 3 systems that develop in sequence, but there's temporal overlap between each of the stages. So there are 3 successive structures of increasingly advanced design, and they primitively function until they're replaced by the adult kidney, which is really coming from the 3rd stage of this 3-staged system. And this in humans arises at about day 32 to 35. So this is showing from the caudal, from the cranial to the caudal system in the embryo, and you have a pronephros, which starts here, and then a mesonephros here. While this 2nd stage is forming, the 1st stage is disintegrating. And then the 3rd stage is where the definitive kidney comes from, and it's all the way down here. I'll break down these stages in the next slides. So the first kidney is the most immature form of the kidney, and in week 4, you have this mesonephric duct. It's in purple. In all of my slides, it will be purple. And this develops along the 5th to the 7th cervical axial levels, and it's a tube. It's an epithelial tube that develops from that intermediate mesoderm, which when we saw was just a cluster of cells. So that differentiates and forms a tube. Then you have here what are called pronephroi. These are still mesoderm cells, so they're undifferentiated cells. They're not epithelial cells. And these are forming and actually joining this tube. And you have clusters of cells which start at cranial and develop more towards the tail. These don't function, and they disappear by day 24, day 25. While those are disappearing, then you have this mesonephric duct, this tube that's still present in purple here, and it's developing and extending to the bottom of the embryo. Now these mesenchyme structures, they're continuing to grow, and they're fusing with this purple structure. Then in yellow here you have the cloaca, and this is also called the terminal hindgut. It's a transient structure, and later on it's going to divide into the rectum, bladder, and genital primordia. And I'll show you some slides of that later. So the next slide shows a cross-section in this direction. And here's the mesonephric tubule, and now this is starting to epithelialize and form a tube, and that's connecting into that original epithelial tube, the mesonephric duct. And these individual structures, there are about 40, and they'll form in succession from the top of the embryo to the bottom of the embryo. The cranial tubes regress in turn as the caudal tubes differentiate and form. So by week 5, there are 20 pairs that are left over, and they're located in the first 3 lumbar levels of the embryo. And these differentiate into primitive excretory units, and they begin to produce small amounts of urine around week 6 to 10. It's not a significant amount, but it's really the first functional kidney. Those continue to disintegrate as development progresses, and then by day 28, this is where the definitive kidney is forming. Growing off of this tubule is the ureteric bud, and this is just a bud. It branches off of the mesonephric duct, and it invades here this metanephric mesenchyme. So the tip invades this undifferentiated mass of cells, the mesenchyme, and these are also derived from the intermediate mesoderm. So the ureteric bud grows into this mass of cells. This first step is called induction, and basically the mesenchyme has a set of molecular signals. It sends it to the ureteric bud. The ureteric bud has receptors that receive the signals and then send its own set of signals back to the mesenchyme. So there's this reciprocal crosstalk between these 2 primordial tissues. That will cause the ureteric bud to branch, and it branches a number of times to form a tree. And it'll also cause this metanephric mesenchyme to form epithelial tubes. So I think, let's see, okay. I went through that. So perturbations at any step of this reciprocal crosstalk, either genetic mutation, malnutrition, or things that happen inside the uterine environment, can inhibit kidney development and result in renal hypoplasia, which means a small, underdeveloped kidney, or agenesis, which is a total lack of a kidney. On the other hand, if there's a duplication or overproliferation of structures, for example, a gain of function during development, there can be a larger kidney and overproliferated kidney. The other thing that's occurring while this is now in purple, these are all the structures derived from the ureteric bud, and in pink, these are all the structures that are derived from the mesenchyme. So these purple ureteric structures divide and branch just like a tree. There's also a bit of remodeling that goes on. So the original branches, they fuse together and they end up forming the calyces in the kidney. So here's the calyx, a minor, major calyx, and the renal pelvis, which is actually where all of the urine collects and then flows into the bladder downstream. And here are the derivatives of the mesenchyme and ureteric bud derived structures. So again, the mesenchyme derived structures are in pink, and you can see them down here in the form of one nephron. You have the ureteric bud budding into the mesenchyme, and then you have these signals that are causing the mesenchyme to form tubes. At the same time, the ureteric bud is branching, and there's, we don't know how, but a connection is formed between these tubes, which are initially separated. Form a connection so that we have one contiguous nephron. So from the mesenchyme, we have these proximal structures, the podocytes, the cells lining Bowman's capsule, proximal convoluted tube, the loop of Henle and the distal convoluted tube. And then the ureteric bud basically comprises this branched collecting system, which is this small connection here, the collecting tubule, and all of the collecting ducts. The ureters, too. Okay. So the kidneys initially start out in the pelvis, and they ascend within the embryo between weeks 6 to 9. There's also embryonic growth in this direction, so the lumbosacral region is growing and extending down. And as the kidneys ascend, they're vascularized by arteries that originate off the aorta. And so higher connections are established while inferior branches are lost as the kidneys move up into the lumbosacral area. Now, while this is going on, the bladder is also forming from that structure here in yellow, the cloaca. And this is an endoderm-lined chamber, and this connects to the surface ectoderm. It also communicates with the allantois here, and this is going to give rise eventually to the umbilical vessels, and also here contributes to bladder formation. Later in development, there's this growth here, which is going to, this is the urorectal septum, and this is going to separate the ventral portion, which is going to form here the bladder and the urogenital sinus, from the dorsal portion, which is going to develop into the rectal and anal canal. Okay? And here is a more fully formed septum. If we look at the bladder from the dorsal side, the bladder here, we have this mesonephric duct, and it has inserted into the bladder. This is that ureteric bud, which buds off the mesonephric duct and forms the kidney over here. And the bladder will grow and expand, and as that does, the distal ends of the mesonephric ducts are absorbed into the wall. They also grow and expand, and they form this muscular structure called the trigone. Now, the amniotic fluid is supplemented by urine production at about week 16. And in intrauterine environment, the amniotic fluid, the kidneys are not functioning to clear waste products like they do in the adult. But urine production supplements the amniotic fluid, which is key to normal intrauterine development. If there is an amniotic fluid deficit, that's called oligohydramnios, that can cause, the main defect is pulmonary hypoplasia. So while the fetus is developing, it has an inhalation or breathing movements, which causes this amniotic fluid to get inhaled into the lungs, inhaled in quotes, and that fluid volume and pressure helps the lungs develop, branch, and expand. If there's renal agenesis, meaning that there are no kidneys formed, and a lack of amniotic fluid, then the lungs don't develop, and that's a lethal phenotype. A lack of amniotic fluid can also restrict fetal growth, and because if there is not a cushion of amniotic fluid around the fetus, it can cause deformities basically due to space constraints. So now I'll talk about the errors in kidney development that we see here in the clinic. There's fetal origins of adult hypertension and renal disease. So earlier when I said that a lot of disease later in life is caused by intrauterine events, there's a link between low birth weight or prematurity or errors in kidney development and diseases later in life, hypertension, glomerular sclerosis, albuminuria. The theory behind this is when there is any of these factors resulting in low birth weight, there's a decrease in nephron number. And I'll talk about all the things that we know that can decrease nephron number. When you have a low number of nephrons, the total renal filtration surface area is decreased. But this is still seeing a large cardiac output. It's seeing a normal cardiac output. So this cardiac output over decreased surface area is putting stress on the kidneys and causing damage that over time leads to these common diseases. These are the risk factors just for a low birth weight: smoking, hypertension, socioeconomic status, nutritional status, poor prenatal care, prematurity, low maternal height or mother born small for gestational age, insufficient weight gain during pregnancy, and malnutrition in the third trimester. And this is just a percentage and number of low birth weight infants over the world. This data was from 2000. And this is percentage of low birth weight, defined as less than 5.5 pounds. These percentages are getting up in 5 to 8% in some countries. And these infants are 20 times more likely to die than their normal weight baby counterparts. So measuring nephron number in human kidneys, humans have on average 1 million nephrons. It's difficult to do and it's really boring, but we have some estimates of nephron numbers that were measured in cadaver kidneys. And the first thing to notice is that the range is remarkable. We have some estimates that are in the 200,000 number of nephrons per kidney, and some over 2 million. So this wide range is remarkable. I can't think of anything else in the body that has such a wide range of values that they pull out from what seem to be normal populations. And so, like I was saying earlier, there's an association between an adverse fetal or early postnatal environment and the development of hypertension and renal disease later in life. Okay. And so low birth weight, like I said earlier, is associated with hypertension, chronic kidney disease, and proteinuria. Okay. We don't understand what the basis of this marked range in nephron number is, but it seems to be determined by how efficient the intrauterine development is. Remarkable for humans, this is not true of every animal, but once the baby is born, nephrogenesis doesn't continue after birth. So prematurity alone is going to result in a deficit of filtration units. So these are the factors that we think influence nephron number during development. Aside from low birth weight, maternal fetal malnutrition, placental insufficiency, intrauterine growth restriction, steroid exposure, antibiotic exposure during pregnancy, and mutations. So in rats and in a number of other experiments, I'm just showing one, the number of glomeruli here, low glomerular number, high glomerular number, inversely related to systolic blood pressure. There was a study in humans where they looked at car accidents on the Autobahn. This consists of 20 subjects between the ages of 35 and 59. And they divided them into two groups. One group had no other history of disease except for hypertension. The other group, no known history of any chronic disease. And when they looked at the patients with hypertension with a matched counterpart, so they matched them for sex, age, height, and weight, the average glomerular number in the patients with hypertension is 700,000, but in the matched control it was double, so 1.4 million. So right here in 20 subjects, this is the range. The other evidence from intrauterine studies, this is a ultrasound that was done on fetuses, and basically they're looking at normal fetuses with normal growth in the solid circles, and then they're looking and comparing to growth-restricted fetuses, so fetuses for their gestational age who were small, and those are in the open circles. The kidney length was, there was no difference in the kidney length, but the growth-restricted fetuses had a shortened anterior-posterior diameter. So the kidneys actually looked sausage-shaped. The other association of low birth weight that's been found is a more rapid progression of other kidney diseases. So if you're a patient with IgA nephropathy, membranous, minimal change, chronic pyelo, or FSGS, if you were a baby born with a low birth rate, there's a more rapid progression of your disease. The other thing in that this study was done here is that low birth weight alone was a risk factor for secondary FSGS. So in these cases, if you have the disease, you're more likely to progress. In this case, if you have low birth weight, your risk of FSGS is increased. So this is a breakdown of the stages in kidney development. Here is that original budding event, and here you can see the ureteric system forming these tree-like branches, and then everything here in pink is mesenchyme-derived, everything here is ureteric bud-derived. And there are a number of steps along the way where if there are defects, kidney development, for example, if this step is abolished and ureteric bud does not grow out, you can have a total lack of a kidney. If you have a couple of ureters bud out, then you can have a couple of ureteric buds. You can have a duplicated kidney or multiple ureters. If there's a decrease in this branching or growth, decreased nephron number, and then in forming the nephrons themselves, there are dysplasia phenotypes, and in terms of, for example, tubule defects like cystic defects can lead to polycystic kidney disease. So there are multiple steps along the way where defects lead to a number of diseases later in life. So this is just induction. This is probably the best studied event in kidney development, and this is that budding into the metanephric mesenchyme. So in the cell where this budding occurs, here's the mesenchyme sending a signal over and activating a number of signals that go back. So any defect in any one of these here, these are all transcription factors, can eliminate that initial budding event. So there's a lot of room for error. And don't memorize any of these genes, but these are some of the genes that are involved in different pathways that we've seen mutations in kidney defects in. These are just the ones that we've identified. So this is John Barash studies iron metabolism in the kidney, and he gave me some kidneys to look at that basically the mother had been put on a low iron diet. So based on how anemic the embryos were, this is a normal mouse kidney in the middle of kidney development. This is the ureteric bud branching system. And depending on how iron deficient the embryo was, and this was the most iron deficient, this is to scale in an age-matched iron deficient kidney. Okay. We looked at a couple of other ones, iron deficiency, vitamin A, FGF7, which is one of those growth factors that is involved in development, and protein deficient. And compared to a normal kidney, they all had different defects. Actually, this protein deficient kidney looks almost like what they were describing as a sausage-shaped kidney. So this is just putting a female mouse on an iron or a diet for 2 weeks prior to gestation, and this is the renal defect. So K-cut is a category of the renal abnormalities we see in the clinic. It stands for congenital anomalies of the kidney and urinary tract. And it's common. These are detected in 1 in 500 of fetal ultrasound examinations. There are probably plenty that we don't detect grossly during screening ultrasounds. And they represent 20 to 30% of all anomalies that are identified prenatally. Worldwide, 50% of childhood kidney failure is attributed to K-cut. And the primary insults can be environmental or genetic. And these are the abnormalities that fall into this grouping: hypoplasia, dysplasia, lack of a kidney, cystic kidney, horseshoe and duplex kidney that I'll talk about later, reflux, hydroureter, hydronephrosis, obstruction at the vesiculoureteric junction, or obstruction at the ureteropelvic junction. So first is renal agenesis, and basically this is a failure of the ureteric bud to reach the mesenchyme, and it's often due to disruption in these molecular signals that they send back and forth. A lot of the times it's accompanied by abnormalities on the same side. There might be a small bladder, absent bladder, a missing ureter, or sex organs, and when it's unilaterally, it occurs in 1 to 1,000 births. There are plenty of people who, when they hear I'm a nephrologist, say, oh yeah, I only have one kidney. Usually that's discovered incidentally, and so we think that occurs in 1 to 1,000, 1 in 1,000, and it occurs more often in males. Bilaterally, if you're missing kidneys on both sides, this is a perinatal lethal phenotype, and that's from the pulmonary hypoplasia. And we estimate that occurs in 1 to 3 to 6,000 pregnancies. This is an example where the urinary tract has been duplicated. Usually there may be this ureteric bud, which may branch prematurely, or there may be two different ureteric buds where one escapes and starts forming its own kidney. And here's an example of a kidney that's been partially duplicated. This one down, that's more in the pelvic region, has its own vascular supply. There can be abnormalities in this ascent. If you remember, the kidneys start out in the pelvic area, and as the embryo grows, they move up toward the cranial region. And they ascend through this fork that's formed by the umbilical arteries. Failure in ascent can result in a pelvic kidney, for example here, and it sort of gets stuck to the iliac artery and doesn't ascend up with its partner. If they're ascending in close proximity, then the lower poles of the kidney can fuse, and that can prevent them from ascending as well. This is called horseshoe kidney, and it's found in about 1 in 1,000 births. And basically here, accessory renal arteries are common, and so there may be more than one artery that supplies the kidney. As it doesn't ascend, you don't have the loss of the lowest artery. Here I have here. So in a kidney that didn't ascend, as the kidney ascends, the lower level blood vessels disintegrate and higher ones form, but here there are 3 separate renal arteries, and this was found in a kidney donor. So the transplant surgeon always has to be aware of the vascular architecture of any organ that they're going to transplant. So now I'm going to talk a little more about the bladder, and this is vesicoureteral reflux. And this is passage of the urine from the bladder backwards into the upper urinary tract. And again, this is relatively common. It's seen in about 1% of newborns. There are 2 forms, primary, which is the most common, and secondary. And there's a strong genetic predisposition of primary reflux. We don't know the mode of inheritance. It's 3 times more likely in white children, and there are a number of genes that play a role in ureter formation, and we've found that 2 of them, SLIT2 and ROBO2, can cause defects in familial reflux. And this is how it usually gets identified. Through prenatal screening, an ultrasound will show hydronephrosis. So there is this back pressure of urine into the ureters and higher up into the kidney that causes dilatation of the kidney. That's what hydronephrosis is. 10 to 40% of fetuses that are diagnosed with hydro in the ultrasound will also have reflux postnatally. Primary scarring is frequent, so the kidney will be hypoplastic, small, or dysplastic with abnormal structure. It happens more often in male than female, and the grade of reflux and the number of renal scars will identify a risk group that has a higher predisposition to kidney disease, renal injury, and even end-stage renal disease. Sometimes this is diagnosed postnatally instead, and usually there's a febrile illness, which is usually a urinary tract infection, and postnatally it's predominantly female. The pathogenesis is really unknown. This is one theory. There's an anti-reflux mechanism that occurs during bladder contraction. So here's the ureter, and it's going through this muscular wall, and it's tunneling through the wall of the bladder. So a normal ureter would have a fair amount of it within the bladder wall, so that when the muscle constricts, it will close the tube, and it won't allow this backflow of urine in this direction. If it's inserted, if the insertion comes out at a higher level here or here, there's not a lot of wall that's going to compress this tube and close it, and it allows urine to backtract up into the upper urinary tract. Here's another example just showing that if you have this redundancy in the tube and the wall closing in this direction, it will shut this off to the urine, as opposed to this case where shortening contraction of the bladder wall is still going to have allow leakage and backtrack this way. This is secondary reflux, and usually this results from a normally elevated bladder pressure. So anatomically, in young, usually boys, there's something called posterior urethral valves. And basically there's a tissue remnant, and we don't know what the origin of this tissue is. And basically it's not allowing proper closure at the bladder-ureter junction, and it leads to, again, backflow and hydronephrosis. It occurs in 1 out of 8,000 boys, and 10 to 15% will end up with end-stage renal disease. And also, there's a lot of incontinence, there are recurrent infections, and then the renal failure. And then there is also functional bladder obstruction, where at the level of the bladder, in the case of neurogenic bladder, where it doesn't empty fully, or in the case of enlarged prostate, the urethra itself is obstructed, and that leads to backward pressure on the upper urinary system. And there is a grading system where basically on the left you have a normal kidney and ureter, and on the right, depending on how severe the obstruction is down here, hydroureter and hydronephrosis. And the higher the grade, the more likely the greater likelihood of end-stage renal disease. So let's go back to the case. This is a 35-year-old man, and he has no known past medical history. He has 2 sons, age 15 and 10, with reflux and renal anomalies. And the oldest son was evaluated at 18 months for growth failure. At that time, he had chronic kidney disease, bilateral reflux, and visual impairment. At age 2, he had undergone ureteral reimplantation. The second son had severe visual impairment, optic nerve abnormalities, and mild renal dysfunction with grade 2 reflux. The father had no renal problems recognized during childhood. So here we have a father, 2 sons with renal abnormalities, a lot of reflux. There's also visual impairment. The father's blood pressure was 150/100, and an ophthalmologic exam showed severe myopia and bilateral colobomas. Auditory testing revealed mild sensorineural hearing loss. Lab data was notable for 750 milligrams of proteinuria, and his creatinine was 2.1. On ultrasound, he had small kidneys. So he has visual impairment, he has hearing problems, he has protein in the urine, and with a creatinine of 2.1, he has significant chronic kidney disease. On ultrasound, the presence of small kidneys show that this kidney disease has been probably ongoing for some time. This is an example of an optic nerve coloboma. It's this structure here, which is abnormal, which is an excoriation in the optic nerve. This is like a bowl-type pouching out, where there's been a failure of the normal joining of different tissue types. And here in the kidney biopsy, there's a lot of mesangial scarring and fibrosis. So this is an autosomal dominant disease. The father and both of his sons had the disease. The current prevalence is unknown, and this is a mutation in a transcription factor that's called PAX2. And PAX2 is in the kidney, it's in the eye, it's in the ear, and it's in the CNS. And this is essential for differentiation of the mesenchyme in the kidney into epithelial tubules. And here, I'll just show you where it is. Here's this initial budding event. And PAX2 is a factor that's expressed very, very early on that is one of the factors that sets off this induction process, sets everything in motion. And it's found in the mesenchyme, and it's sending the signals over to the ureteric bud. So the eye also has its version of eye mesenchyme, and the ear does as well. So the PAX2 mutation caused defects in all of these organ systems. So the ophthalmologic findings come from abnormal growth of this periocular mesenchyme into the developing eye. Over 20 heterozygous mutations in PAX2 have been described, but sometimes we can't find, we don't know all, that's just a partial list. And there's a wide familial phenotypic variability, even between individuals carrying the same genetic mutation. Most patients will develop end-stage renal disease. So in this case, the first child became evaluated when he was a toddler, but in the father, it wasn't until he was at age 35 that he started to have outward symptoms and became evaluated. Another syndrome is Townes-Brocks syndrome. Again, here's another factor, SAL1. It doesn't seem to be as prevalent, but it occurs in 1 in 250,000 live births. And again, there is dysplastic ear development, hearing impairment, and 30% of these patients will develop end-stage renal disease. These are some of the structural malformations: horseshoe kidney, kidney hypoplasia, polycystic kidneys, and reflux. Wilms tumor is an embryonic cancer that arises from defects in these sort of developmental mechanisms. And this is the most common form of childhood kidney cancer. It's rated fourth in overall incidence of all childhood cancer, with an onset of about 2 to 5 years. And the presentation is a palpable abdominal mass. It's usually painless, hematuria, fever, and hypertension. There's usually a unilateral tumor with a fibrous capsule, but 5 to 10% are bilateral or multicentric, and they also occur in the presence of other urogenital malformations. The origin's unclear. There are some genes that we've been identifying that are involved. There are Wilms tumor genes, WT1, WTX, this is a beta-catenin, and those are detected in about a third of the cases, but there are a lot of cases where we don't know what the genetic etiology is. And Wilms tumor 1 encodes a transcription factor. So the loss of WT1 or the overexpression of WT1 is associated with the different phenotype characteristics we see depending on when it occurs and what the differentiation status is. So patients who have WT1 in particular have an increased risk of bilateral disease and recurrent disease. This is what we think about the cellular origin. This is normal kidney development. This is the ureteric bud branching. This is the undifferentiated mesenchyme here becoming developed. In Wilms tumor, however, you have different cell tissue compartments disorganized. Here is an epithelial tube. Here is a capsule that has undifferentiated mesenchyme. And here is stroma, smooth muscle components. So all of these within the tumor are disorganized and growing. So you have different primordial tissues growing together in a disorganized fashion. You'll get a lecture later on cystic kidney diseases, and I'll just wrap up with a lot of the things we don't know. We have a poor understanding of the abnormalities that underlie bladder and ureter defects. There are a lot of genetics involved that we don't have insight into about the pathophysiology of reflux, posterior urethral valves. The posterior urethral valves cause outlet obstruction, and these are generally diagnosed when hydronephrosis is observed on ultrasound. But we don't have insight into their etiology, and we don't really know the tissue of origin. They may be remnant sex ducts, or they may be abnormal growth of the tissues we've been talking about here. We don't have a good understanding of how glomeruli and the developing kidney tubules become vascularized. We know that the vascular system tends to mirror what's happening with the nephron, but how that develops and invades the kidney during development is really unknown. And we have some insight into the link between nephron number and hypertension, but the instructions that specify what nephron number is supposed to be, or the instructions that tell the kidney you're done developing, are really basically unknown. So this is just an example. This is a mouse kidney, and this is the ureteric bud branching. And so we mapped the ureteric bud branching in the mouse during development, and basically it divides, almost bifurcating to form this tree. So you can imagine that if a baby is born prematurely, let's say let's say a mouse is born 2 days prematurely, if this bud is dividing each time and you lose one bifurcating division, you've lost 50% of nephrons. So that's why it's important to screen, do prenatal screening, make sure that prenatal care is available, even all over the world, but even in this country. Okay. And I'll take questions up here if you guys have any. Yeah, I'm just going to
check your mic. There you go.
Thanks. Hopeless. I'm going to put it in my pocket. How about that? Good morning, everybody. Let's try to get started. Many years ago, maybe 10 years ago, I think, or 15 years ago, I was giving either this or the acid-base talk, and the computer crashed. It was like the beginning of audio-visual problems. And, you know, I had to use the board. And, you know, since I've been giving these talks forever, it wasn't that difficult. But after the talk, one of the students came to me and said, you know, this was so impressive that you actually knew this, that you could do it on the board, you know. So the poor kid doesn't think that, you know, at Columbia we have actually experts who give these talks. We don't just read the chapter in the book the night before and then regurgitate it to you. Okay, we're going to talk about potassium today, which you have already heard about a lot and maybe gone over some of the important aspects of it. But today I just want to go through it formally, you know, from the beginning, so that we are able to intuit in many ways, you know, what is going on. And the nice thing about potassium metabolism is, of all the areas in kidney physiology and pathophysiology, it's probably the area we know the most about. Although there's always room for, you know, more knowledge. Okay, so the most important issue in potassium metabolism is, unlike most things we have been dealing with, we obviously have to always deal with the steady state, which means how much you get in and whether the kidney or other systems excrete sodium or water or whatever. In terms of potassium, we have to add something really important, which is that the majority of plasma potassium, maybe in excess of 90 or 95% of the total body potassium, is really not in the plasma. It's mostly in the cell. You already know that from the past, that the major cation of most living cells, you know, there are a few bacteria in which sodium is the major intracellular cation, but essentially you would say the absolute majority of all cells are like ours, which is that they are full of potassium and their sodium concentration is very low. It's maybe 10 times lower than the potassium concentration, and as you already know by now, it's the reverse outside. And so the maintenance of these gradients across cell membranes is probably the most important characteristic of life there is, you know. Of course, I keep changing my mind. I told you acid-base balance is the most important, but, you know, what can you do? Consistency is, as they used to say, only for mediocrities. All right, so what does that mean? It means before we used to be able to, you know, conclude about the state of a condition such as, say, volume depletion or hyponatremia or hyperosmolarity or whatever from simply measuring the plasma concentration. Now I think we have to, you know, while measurement of the plasma concentration of potassium is very critical and really important, we have to add something else to it, which is to say, in what way does the concentration in the plasma reflect what is present in the total body, and how do we deal with these kinds of things? With that in mind, let us sort of talk about the overall balance of potassium. So first, let me just introduce the idea for you, which you already know a little bit, which is that the fact that intracellular potassium is so much higher than extracellular potassium and vice versa for sodium means that the relationship between intracellular and extracellular ions is very critical and maintained at a very high cost of energy, and probably 50% of our ATP utilization at rest, or even probably during exercise, is simply spent on maintaining these ion gradients across cell membranes. And why is that? Well, because it turns out that the electrical potential across cell membranes is an incredibly important parameter that is used for almost anything you can think of, including thinking, of course, which is excitability of neurons is essentially based on the maintenance of these electrical gradients and their change. So how does that happen? Well, we have in our genome 70 genes of potassium channels. Potassium channels are just essentially holes in the cell made of proteins with a sort of water pore that is very selective to potassium over sodium. On top of these 70, we have like 70 genes, but each potassium channel is made of 4 of these genes. So you can see, those of you who can do the probabilities, it's like 4 to the 70 types of potassium channels we have. And every cell has many more than one type of potassium channel. A few of them are dominant, and they control the membrane potential, but that's really, when we think about potassium channels, we think about like a large universe of characteristic proteins with their different components. So there's a very important equation that determines the membrane potential, and it's called the Nernst equation, which, these are all constants. It's simply a reflection of the inside and outside concentration of potassium. So in most cells, the membrane potential is determined by that, and if you plug in the numbers that I had here into this equation, these constants are, easy to look up on Google, you end up with minus 80 millivolts. So most of our cells are negative inside of around 80 millivolts. We will talk about a little bit about that, but we won't spend a huge time on them. Okay, let's talk about general potassium balance. So potassium balance, of course, we eat all of our diet, I shouldn't say all, but the majority of our diet is cells. We eat, whether it is lettuce or steak or whatever, or chicken, we're only eating cells, and therefore we have there is no such thing as a low potassium diet, except if you are very faddish or that you have certain kinds of problems. We got consulted, Dr. Radhakrishnan, who you have met already, got consulted by a group in India who had suddenly got an epidemic of severe hypokalemia and paralysis. We'll talk at the end of the lecture how that happens. And they couldn't tell. They were all worker farmers in the field. Of course, you can lose a lot of potassium in sweat, but they should be replacing it with food. Of course, Indians eat lentils and rice, which are not cells, actually. They are storage granules in plants, so they don't have cells. So in fact, it's a very low potassium diet. So if you only eat lentils and rice, you will become hypokalemic. But the majority, all of us, we have to think that every diet essentially is a high potassium diet, and there are some that are higher than others. If you eat only leafy vegetables, you have a very high potassium diet, which turns out to be good for you, as you already know. Okay, so potassium intake, it's all reabsorbed. Once the cells are destroyed in the GI tract, the potassium is absorbed and then goes into the blood. And in the blood, the first thing that happens is that it exchanges across the cell membrane, because there is this very famous enzyme, sodium-potassium ATPase, that actually pumps potassium into the cell and pumps sodium out at the expense of the ATP I told you about, which is half of the ATP utilization of the body. So the first thing that happens is that the once the potassium comes into the extracellular space, which is only 2% of the total body potassium, it quickly exchanges with the intracellular space. Now comes really the interesting thing. Now what happens? So here I think it will be interesting to look at my hand-drawn graph, and I don't have like a very fancy figure making app. So here, if we eat potassium, and you look actually at the plasma potassium over a period of a few hours, you will see that the plasma potassium will go up from, let's say, the average of 4 to maybe 4.5 or something like that. But then it will disappear. So why does it go down? Well, it goes down because some of it goes into the intracellular space, and some of it is excreted in the urine. So that's really what we will be talking about. Now comes the interesting thing of what regulates the equilibrium of potassium between the intracellular and the extracellular space. And a lot of things actually do that. So the three critical ones that we need to remember are the following. Acid-base balance, incredibly important. So if the person happens to be acidotic, you will find that for the same amount of potassium that we ate, let us say, just 1 kilo of spinach, so that we get a big signal, it will be much higher if the person is acidotic, and much lower if the person is alkalotic. And the decay, in other words, the excretion, both the equilibration across cell membranes and the excretion by the kidney will be slower if the person is acidotic, and will be faster if the person is alkalotic. Therefore, acid-base balance has a dramatic effect on exchange of potassium across cell membranes, of which, of course, the kidney, being made of cells, will also participate in. And so how does that happen? Here is one of the few things we don't know anything about. But let us call it that there is a potassium-hydrogen exchange in the cells. I don't like that word because it doesn't exist. There's no gene that conducts potassium in one direction and hydrogen in the other, like there is with the sodium-hydrogen exchanger. But it makes life much easier if we think of it like that. So in other words, when you have acidosis, you push hydrogen ions into the cell in exchange for potassium coming out. So essentially, and when you have alkalosis, it's the opposite. You push hydrogen out of the cell in exchange for potassium going in. And there is no doubt that that is what happens. How that happens, whether there is a real gene that exchanges them, I think so far people have not found it. But the process is very clear that it happens. So let's just call it potassium-hydrogen exchange across cell membranes. Okay, so that's a very critical and probably the most important regulator of exchange of and redistribution of potassium between the extra and intracellular space. The next is insulin. That's a really interesting and, of course, clinically incredibly important phenomenon. Everybody who has diabetes is generally more hyperkalemic than an equivalent person who's identical in everything else. And the reason is that insulin is a very critical determinant of how much potassium gets into the cells. And insulin, how that happens, there are lots of studies that suggest that insulin simply increases the activity of the sodium-potassium ATPase by pumping more potassium into the cell. And of course, during the whole day, we always have a little insulin in our blood. It can increase when you eat or decrease when you are starving, but still, it's there and is an important determinant, especially in clinical conditions of either insulin excess or insulin deficiency diabetes. So much so that one of the first things we do if somebody comes to the emergency room with severe hyperkalemia, and we want to really make sure we correct it quickly, is we would give them sodium bicarbonate and give them glucose and insulin immediately. And the effect of these things will be instantaneous, will be under your very eye. It happens over the next few minutes. Okay, there's another thing which has a reasonably interesting effect, and it's a modest effect, but it's something we see clinically, therefore we have to talk about it, which is the role of the sympathetic nervous system. Epinephrine, similar to insulin, increases the activity of the sodium-potassium ATPase and causes more pumping of potassium into the cell, and beta blockers obviously prevent that. So, and that happens, so there are many people with asthma, for instance, who keep taking, epinephrine for their asthma, and they often have low potassium. And in many situations, beta blockers, which are one of the most common drugs used, you have to think about them if somebody comes in with hyperkalemia. The effect is actually quite modest, and we are very conscious of it in the kidney because in many people who have renal failure, where the kidney is no longer involved in the regulation of potassium balance, that could become a significant issue. And is one of the things we get consulted on is hyperkalemia of obscure origin. It's not obscure, it's fairly evident. Okay, so then whenever we ingest any potassium, we end up redistributing. We call it redistribution of potassium, and then some of it is excreted, and of course eventually even those that are redistributed will come out over a slower period of time. So what about the kidney? Now the kidney, a very important organ for the excretion of potassium, probably the central organ for it. That doesn't mean it's the only one, as we will talk about later. The sweat gland, the GI tract, all of them can have an important role, except especially in diseases, but the kidney is really what counts in the disposal of potassium, of the daily intake of potassium. So how does it do that? Well, potassium is freely filtered with a small ion, and 95% of the filtered potassium is reabsorbed in the proximal tubule and in the thick ascending limb. And eventually some of it is absorbed in the distal tubule. And what appears in the urine is largely not what was filtered. It is what is secreted by the collecting duct. So that's, the kidney is very cute in these kinds of things. It does funny things. Absorption, 100% absorption, and what comes out in the urine comes out afterwards, Don't ask why, since the answer to why is always a religious sort of question here. All right, so how does it do that? Let's talk about the collecting duct, because that's sort of where we really should spend a lot of time on how these things work. Well, you remember that the collecting duct has two kinds of cells, intercalated cells, which are responsible for acid-base balance, and then the principal cells, which reabsorb sodium. There is the sodium channel ENaC, and then the sodium channel goes in and then comes out by the sodium-potassium ATPase, but there is also a potassium channel, which is called ROMK, which we will talk about later. So this potassium channel is present here. There is also an ATPase on the luminal membrane that is like the stomach ATPase, which supposedly exchanges hydrogen for potassium, And in states of severe potassium depletion, actually it gets induced, and then we can absorb the potassium from the urine. However, we need to think about one thing, is that if you go on a zero salt diet, as we have been talking about, the urine sodium excretion can essentially go to very close to zero, which is pretty astonishing when we think about it. The urine, for the sodium concentration to go down to 1 milliequivalent per liter, when the sodium in the blood is 140, that's like an incredible gradient. How does it do that? It's you already know. I mean, that's a rhetorical question. With potassium, that's not really the case. If you go on a zero potassium diet for a long time, you'll become severely hypokalemic, and the reason is that the kidney cannot reduce the potassium excretion to zero. There's always a lot of potassium in the urine, and it's a problem. That's why we always need to eat, potassium. What's the reason for that? Who knows? But one likely thing is that, the kidney got constructed because many animals don't eat like we do, 3 or 4 or 5 times a day, each time hopefully small amounts. Many animals, eat, like a lion goes out and they eat one gazelle, once a week. So what happens when you eat this giant animal, you get flooded by massive amounts of potassium. It could kill you, essentially, if the kidney was not geared to excretion of potassium. So the kidney is basically an organ that excretes potassium. And whenever there is hypokalemia, most of the time, it's the kidney that's causing it, that's causing the hypokalemia, because it's an organ that is geared to excreting potassium. Okay. So now we need to think about, well, how does potassium get excreted? Well, we need to think of the driving forces for potassium secretion. So the intracellular potassium is very high. By the time the urine comes to the collecting duct, most of the potassium has been reabsorbed, so the concentration in the urine is very low. Certainly much lower than the intracellular concentration. And therefore, there is a big gradient for secretion of potassium. But of course, if there is no open potassium channel, you won't secrete any potassium. So we need a potassium channel to have this gradient act on it. Another is the membrane potential. Well, potassium is a cation, so if the lumen is very negative, just like we talked about with hydrogen ion secretion, we will get much more potassium secretion. So the driving forces are concentration differences and electrical differences across the membrane. That's why we need to think, when we talk about the concentration difference, what determines the intracellular concentration? We already talked about that. Acid-base balance, insulin, beta blockers, all of these things affect the intracellular concentration of potassium in the collecting duct as well as in every other cell you can think of, but in the collecting duct, so it affects potassium secretion that way. Okay, so potassium channels, they exist in 2 varieties in the kidney. One of them is called ROMK, which is a small conductance potassium channel, which is generally responsive to potassium secretion. But the most important factor that affects potassium secretion turns out to be the urine flow rate, which is a very puzzling phenomenon. Okay? So if you look at the potassium secretion in the collecting duct as a function of the urine flow rate, you find out the more urine flows, the more net potassium secretion there is. And if you put animals on a very low potassium diet, the whole thing collapses, but there is still an effect of urine flow rate. What does low potassium diet do? We will talk about it in a few minutes, but it just simply lowers the aldosterone level. Aldosterone is very important in both responding to potassium levels in the blood and controlling potassium levels in the blood. Okay? And if you put animals on a high potassium diet, which stimulates aldosterone release, which, as I said, we'll talk about it in a minute, there is still an effect on the flow rate, but the effect is magnified in massive amounts. So the total amount of potassium excreted by the kidney in many cases is dependent on the urine flow rate. That's why people who have oliguria, in acute renal failure, are often hyperkalemic, regardless of anything else, because you need a good urine flow rate to excrete a lot of potassium. So how does that happen? Well, it turns out there is another kind of potassium channel that is responsible for this urine flow rate effect, which is called the BK potassium channel. It's present only in the principal cells, and here is, so if you look at the flow rate, in the presence of a high salt diet, so high salt diet suppressing aldosterone, you still get an effect of urine flow rate. In a low salt diet with a high aldosterone, you have a much more sodium absorption as well as potassium secretion. And if you block the potassium channel, BK potassium channel, by this toxin produced by a snail, iberotoxin, you can block the flow dependence, essentially. Okay. How does urine flow rate affect potassium secretion? Well, it turns out that BK channels are calcium sensitive. So here is the channel sort of happily opening every now and then. But if you increase the potassium in the cell from 1.8 micromolar, that's incredibly low, to 5, you see that the channel is open many more times. So it's calcium-dependent potassium channel. Well, that's sort of like kicking the problem to the next block, So how does the urine flow rate affect calcium inside the cell? Okay, first let me just tell you that the BK subunit the potassium is only present in the principal cells, not in the intercalated cell. So it turns out that high urine flow rate increases intracellular calcium in the principal cells. So how does it do that? Well, here we need to go back to grade school, when you were told to go to sort of whatever is a pond near you, take some water, put it under the microscope, and you see these little organisms, Euglena viridis, remember? And they have flagella. It turns out the flagella are very critical in the control of this. So flagella are like a hot area in research today, and there are 400 proteins present in each flagella, and mutations of most of them produce diseases you already heard about, polycystic kidney disease being the most famous, but many other diseases are produced by it. Okay, so if you look at the cortical collecting duct in the kidney, you will see that there are two kinds of cells, one with flagella and the other with a sort of rough border. So these are the intercalated cells, but these are the principal cells. So the principal cells have flagella. So what, you say? Well, some very clever guy took a pipette and sucked the flagella into the pipette, okay? And then he would tickle the flagella and move it a little bit, and find out when he does that, and he measured the membrane potential in the same cell, which is like a heroic effort, you find that the membrane potential depolarizes immediately, and that the intracellular calcium goes up. It turns out that the flagella has calcium channels that are what are called stretch activated. In other words, when you touch them, they increase intracellular calcium. It's an incredibly cute result, Okay, so let's summarize how do we control potassium secretion. Let's just look at it this way, okay? So first, aldosterone, very critical hormone that controls potassium secretion. How does it do that? It increases the activity of the potassium channel, POMK in particular. So there is the channel is more open more of the time. So it increases the activity of the sodium channel. We knew that already. So what does that do? It makes the membrane potential more negative. You can, in the presence of an open potassium channel, you can get much more potassium secretion. And it also increases the expression of the sodium potassium ATPase. So the intracellular potassium is higher at that point. Urine flow rate, well, it brings in low potassium in the tubule, and of course, I don't know what happened to the BK channel that should have been here. There is also the presence of the BK channel. And then, of course, acid-base balance affects the cell potassium. Okay, so let us talk about clinical situations. They are very, very common. Potassium, we measure potassium on everybody, essentially, because we get these electrolytes. And, the minute anybody enters the emergency room, they have their potassium measured. And, a very significant number have either hypo or hyperkalemia. And we need to be able to explain it, and it is incredibly straightforward. So we need to think about, even though I said most people have a high potassium diet, we need to ask people if they are eating. Or supposing somebody has stopped eating, if they have hypokalemia, that could be an important thing. So we talked about, we need to talk about importantly, that the redistribution of potassium between intracellular and extracellular fluid, as well as renal excretion, in addition to the diet. Okay, so you already know this. The redistribution depends on insulin, on acid-base balance, on epinephrine. Diabetics, if somebody comes in and they are diabetic and they have hyperkalemia, there are lots of reasons why they should have that, but one of them is the effect of insulin. Acid-base balance, the same. Acidosis increases potassium, alkalosis decreases it, and epinephrine and beta blockers we talked about. Okay, here maybe. So every single one of these things that normally regulate potassium balance can be affected by diseases, right? So we have many conditions of hyperaldosteronism. We have many conditions of changes in the urine flow rate. And we have already many conditions that affect acid-base balance. Okay? And each of them, we need to think about each of them. How do they affect the driving forces for potassium secretion? The potassium gradient across the cell membrane and the electrical gradient. Okay, so let us talk about, let's say, hypokalemia. So intake, only if severely reduced, such as in malnutrition. I also mentioned, eating non-cellular material. Redistribution, so anybody who has alkalosis is likely to have hypokalemia. And what's the reason for the hypokalemia in alkalosis? There is redistribution, but there is also increased excretion by the kidney. So there's real hypokalemia in terms of the total body potassium, but there may be only redistribution effect. So we need to think about both of them. Insulin infusion, we use that to control hyperkalemia. But when people have, when you give insulin to patients who have, let's say, pretty severe diabetic ketoacidosis, you can see that their potassium can plummet very quickly to low levels. And I mentioned the fact that patients who are especially asthmatics, because they take a lot of beta agonists, they can develop hypokalemia. What about increased loss, So let's talk here a little bit about non-renal losses. So the kidney is the major source of losses of potassium. However, there are many conditions associated with non-renal losses. So, for instance, diarrhea. So diarrhea is essentially increased flow rate. And increased flow rate affects potassium excretion in the colon in the same way it affects it in the kidney. So, the kidney, the GI tract is really like a giant nephron, much dirtier, of course, but very similar. The ileum and the jejunum and the duodenum are very similar in characteristic to the proximal tubule, and the colon is very similar to the collecting duct in many of its transport processes. It can produce gradients, it can secrete potassium, and other things, okay? So diarrhea is a very critical thing, and we always need to ask people about diarrhea when they have hypokalemia, and a lot of the time, we miss it because you ask people about diarrhea, which is a very wrong question to ask patients. You're not interested in what they think diarrhea or constipation is. You want to know how many bowel movements they had and whether they were liquid. You ask that question, you always get the right answer. So diarrhea is very critical. Similarly, sweating, the sweat gland, again, similar to the collecting duct, when you increase the flow rate, you increase the excretion of potassium. And although generally speaking, we don't really see patients who have hypokalemia because of this, it does happen, and you need to be aware of it. In the summer, many people don't have air conditioning, and or people go running in the summer, and lose a lot of fluids, including a lot of potassium. So we need to think about sweat as a cause of hypokalemia as well as diarrhea. In the kidney, the most common cause of hypokalemia by far is the effect of diuretics, because diuretics, as I will explain in a couple of days, decrease sodium reabsorption, sodium and water reabsorption in the thick ascending limb or the distal tubule, and therefore increase the urine flow rate to the collecting duct. But at the same time, the purpose of giving diuretics is to produce volume depletion, which can increase the aldosterone level. So not only do you have hyperaldosteronism, but you also have increased flow rate. So it's a double whammy. No wonder it is the major cause of hypokalemia in clinical medicine. Hyperaldosteronism, I'm going to talk about it in a second, and drugs. Amphotericin B is a drug that we use to treat fungal infection. You may have heard of it already. It's a molecule that combines with itself, and makes a pore, and that's how it kills the fungi. It just punches holes in them. But it's filtered by the kidney, and by the time the amphotericin reaches the collecting duct, it's pretty concentrated. As you know, we filter 200 liters, we excrete 1 liter, so it could be 100-fold concentrated. And so it can punch holes in the membrane of the collecting duct and cause, it's like a big potassium channel. It's a very common problem with amphotericin, patients receiving amphotericin. Okay, let's talk about hyperkalemia, So the intake is not generally critical except if people have renal failure or have pretty significant chronic acidosis. We need to control the diet. So people on an end-stage renal disease on dialysis, they need to be on a restricted potassium diet. As I said, there is no such thing as a low potassium diet, but you have to prevent them from eating high potassium foods, Okay, we need to think about redistribution. So acidosis produces hyperkalemia, diabetes produces hyperkalemia from a variety of reasons. One of them, diabetes, is often associated with renal tubular acidosis. And also diabetes, aside from the redistribution part, actually has, many patients with diabetes have interstitial renal disease with atrophy of collecting duct and the tubules, and atrophy of the juxtaglomerular apparatus called hyporeninemic hypoaldosteronism. So many patients with diabetes chronically are hyperkalemic, in addition to the redistribution part. Then we have decreased renal excretion. I said beta blockers are associated with hyperkalemia, but only in the setting of pretty significant renal disease. So decreased urine flow rate, we already talked about that. But there are other conditions, congestive failure, oliguria, oliguric ATM. In congestive failure, we don't see hyperkalemia, even with severe oliguria, because it's associated with hyperaldosteronism. But we can get it, actually. So hypoaldosteronism, so ACE inhibitors or angiotensin blockers, they affect aldosterone production. And if you block ENaC, for instance, with amiloride or triamterene, these are diuretics that specifically block the sodium channel in the collecting duct, of course decreasing the negative membrane potential and reducing potassium excretion. And interstitial renal disease, and the most common interstitial renal disease is actually diabetes, diabetic nephropathy. Okay, now a very important reason to think that hypo and hyperkalemia are very important, are critical, and we need to really understand what's going on, is the fact that small changes in the plasma potassium concentration have very large effects on the membrane potential. And the reason is that the membrane potential is essentially the ratio of the intracellular to extracellular. So imagine going from a plasma potassium of 3 to 6. That will halve the membrane potential. And that's an incredibly big change. And so this is the reason we really think of plasma potassium changes as very critical things. And look at the manifestations. So hypokalemia, you have muscle weakness. So why does one have muscle weakness? Well, when you have low potassium, the membrane potential is very high. So the intracellular, because the intracellular to extracellular ratio, it just gets bigger, and so the membrane potential will be very negative. And so you can't actually activate the muscle, because to activate the muscle, you need to depolarize it so that calcium can go in. So that's a very critical finding, and you get, as I told you from Jay's patients, consultation, there were wards full of paralyzed people with potassium of 1.2. They're completely paralyzed. All you have to do is give them potassium, and they walk out of the place. It's incredible finding when you see it. Okay, we can also see rhabdomyolysis, which is a complicated story, and in principle, when muscles contract, they release potassium. In hypokalemia, you can't release a lot of potassium because the total body potassium is depleted. And it turns out that this released potassium is a vasodilator, which is the reason we all get hot when we exercise. There's increased blood flow to the muscle. And if you don't have that and you exercise a lot, you can produce rhabdomyolysis because the oxygen consumption goes up, but the blood flow doesn't, oxygen delivery doesn't go up. Okay, and you can get, of course, cardiac arrhythmia that you already probably know about. When the plasma potassium decreases, you eventually get cardiac block, essentially. First-degree heart block is the most common kind of finding that one has. Similarly, with hyperkalemia, which could be fatal, is the same thing. Hyperkalemia means the membrane potential is depolarized, not hyperpolarized, and therefore it's hyperexcitable, and that's why you can get essentially ventricular fibrillation from it. And the characteristic finding is these peaked T waves that you start seeing it when the plasma potassium gets elevated. So always look for the T waves, and it's like an easy way of measuring the plasma potassium by just looking at the T waves. And if the T waves are not peaked, you don't have to sort of completely get agitated, because whatever has happened, maybe the intracellular potassium has also gone up. That doesn't mean you don't have to treat it, but you don't have to treat it within 2 seconds. Okay, so there are a number of genetic syndromes that are associated with potassium metabolism. There are people who have syndromes produced by mutations in sodium channels, and also a variety of other things. Let us talk about Bartter syndrome, because it's associated with severe hypokalemia, but can also be associated with hyperkalemia. Okay, so what is Bartter syndrome? We talked before, I think John might have talked to you about the thick ascending limb. So the thick ascending limb, there is a transporter called NKCC, which transports sodium, potassium, and 2 chlorides. So it is neutral. And it dumps all of them into the cell, and the potassium gets recycled through a potassium channel. And the chloride comes out on the basolateral membrane. So there is a syndrome which is associated with severe volume depletion, high renin and high aldosterone, and hypokalemia, metabolic alkalosis, and mutation of one of the following genes. You can have mutation in this gene, of course, and that causes increased renal flow. This is like having a diuretic. The most common diuretic is called furosemide or Lasix, which acts on this. So it's like having a continuous diuresis, which produces volume depletion, high aldosterone, and hypokalemia because increased flow rate and high aldosterone. That's the syndrome. But you can have a syndrome where ROMK is actually mutated. When you mutate that, that also blocks the function of this, because you can't then, eventually the gradients inside the cell will shut down the transport of this. But in this case, of course, people will have hyperkalemia. They won't have hypokalemia. They will have hyperaldosteronism. They will have volume depletion and high renin. So finally, let me tell you a little bit about aldosterone in the last few minutes here. You know, hyperaldosteronism can be classified into secondary hyperaldosteronism, which is what we have been talking about most of the time. Secondary hyperaldosteronism is when that adrenal gland, which produces aldosterone, is responding to some stimulus in the body. And that stimulus is usually one of two things. Hyperkalemia stimulates aldosterone production, as does angiotensin II. We've been talking mostly about angiotensin II. And that's called secondary hyperaldosteronism. So that means the normal response of the adrenal gland to stimuli. Primary hyperaldosteronism, which is much rarer but still fairly, common enough to see, can be associated with two things: an adenoma of the adrenal or hyperplasia of the adrenal. Let me tell you a little bit about the adrenal, since you haven't had endocrinology yet. So the adrenal has three segments. One of them is called the zona glomerulosa, which is the surface of the adrenal. There's the very few cells, as you see, like maybe 10 cells thick here. And then there is the fasciculata, which produces cortisone and corticosteroids, and then reticularis, and then inside there is the medulla, which produces epinephrine. This is the adrenal cortex, and then adrenal medulla is here. So this is the region that produces aldosterone. So here's a staining for aldosterone synthetase, and you see it's only present here. So how does it work, actually? And recently there have been really exciting developments in our understanding of how aldosterone is made. So there is the angiotensin II receptor, which we all know. And then there are potassium channels, specific potassium channels that are present in the adrenal gland, which are called KCGM5. And then there are calcium channels that are also present. So what happens? When angiotensin binds to this, it actually activates cyclic AMP, and then this blocks potassium channels. And then when you block the potassium channel, the membrane potential depolarizes. That opens calcium channels. And calcium channels control aldosterone synthesis. So calcium inside the cell, when the calcium goes up, it activates a transcription factor, which then controls the synthesis of the enzyme. Now, how does hyperkalemia cause increased aldosterone synthesis? Well, let's put it straightforward to all of you now. Hyperkalemia essentially controls the membrane potential through the same potassium channels, which depolarizes the cell and opens the calcium channel, and therefore causes aldosterone synthesis. All incredibly nice. And recently, there have been lots of mutations found in significant number of families, either in the potassium channel, which have made them to be changed from being potassium channel to conducting sodium. By just changing a few amino acids around the hole, the selectivity of the potassium channel changes, and now this depolarizes the cell, causing increased production, increased calcium, huge increase in aldosterone, but at the same time, the calcium is a stimulus to cell proliferation and causing aldosterone adenomas and aldosterone hyperplasia. Similarly, recently people have discovered, just like a couple of months ago, discovered the presence of mutations in one of the two calcium channels that are present in the adrenal glomerulosa cell. And that allows the calcium channel to be open more often than normal, and therefore producing increased aldosterone secretion. So this is just too busy, I think. So in conclusion, let us just say that in order to sort of think about potassium, we need to think about the redistribution, about the intake, and about the many things that the kidney does to regulate potassium excretion, including flow rate, including aldosterone, including the activity of the sodium channel, And that's it, I guess. So thank you. Hi.
So I had a question about the redistribution slides. So you said that the x-axis was time in hours. Was the y-axis concentration in the serum?
In the serum.
So when it was decreasing, that was partly because it was being redistributed intracellularly,
And partly
because it was being excreted.
excreted. But even, of course, in the steady state, what has been redistributed will eventually leak out, right?
Right.
So
I know you said some of the mechanisms weren't understood, but could you go over again the three categories and why they move in the direction that they do?
for the redistribution. Okay, we'll come over here.
So with acidosis, you were saying is to think of it
Okay,
as
let us think of it in both of them, in all of them. Let's think of it as first we have a sodium potassium ATP that's present in everything. That pumps potassium into the cell, and pumps sodium. Now, let us say that there is a potassium hydrogen.
just for theory.
No. I mean, we know that that's how it works, but we don't think there is a protein exchange. But I don't know how. So,
So it's two separate proteins doing it independently, but they're somehow
who
coordinated.
knows? We don't know. The reason is that the amount, you see, if it was a sodium potassium hydrogen exchange, like sodium hydrogen, that we could tell that for each proton that goes in, one sodium goes out, right? Or two or three or whatever. But there doesn't seem to be, I mean, that's, okay, so when you have acidosis, that will go in and potassium will go out.
So when you say you have acidosis, so you're referring
Let's
to
say
the
you
serum?
drink, just
So
drink
the serum is
hydrochloric acid.
high, so
Yeah.
you'll pump acid into the cell.
Well, there is a gradient going in, right? If the cell pH, if the serum pH goes down.
So you'll become